So the concept of breaking down complex heart failure phenotypes into a 2x2 table, if you will, of either wet or cold patients was first created in 2003 by Noria and Stevenson in Boston at the Brigham. Now this was initially tested in a group of patients who had advanced heart failure, who were patients with heart failure with reduced ejection fraction. What is unique about the current registry analysis is that this takes that concept to a very real-world population that includes not just patients with heart failure and reduced ejection fraction, but the equally common entity of heart failure with preserved ejection fraction. There are many interesting, unique messages from this particular registry analysis. The first point that I'd like to make pertains to the heart failure with preserved ejection fraction population. What I found strikingly novel about this was the fact that even these patients have a group that has hypoperfusion. I would not have expected HFpEF or heart failure with preserved ejection fraction patients to present with hypoperfusion typically. They're usually more congested. This really points to more deeper phenotyping of these patients where we need to understand who that group of patients is. It might be that these patients have valvular heart disease like mitral regurgitation or aortic stenosis that is being missed and maybe an opportunity for treatment. The second important point that I found from this particular registry analysis is the real opportunity. There are three factors that appear to be very critical in adjudicating one-year prognosis. The first is the residual presence of congestion. The second is a patient who is discharged cold or hypoperfused. And the third is right heart failure. If you take these three factors, one can identify a population of patients who are at high risk of immediate decompensation. These are patients who should ideally be referred to advanced heart failure centers where there are structured teams to give them opportunity for either transplant evaluation or for other techniques like left ventricular assist devices. More importantly, I would say that it is incumbent on the society now to take this registry data and start to create interventions for it. And how do you implement this to decrease the burden of heart failure, whether it be by the creation of transitional care teams or whether it be by point of care assays using natriuretic peptides or pulmonary artery sensors. One needs to start thinking about what to do with this data to reduce the burden of heart failure.